Welcome to the recorded version of Home-Based Cardiac Rehab, Designing an Effective Approach from February 28, 2019, brought to you by the American Society of Aging and a generous sponsorship from Right at Home.
Okay, we have two presenters here joining us today. David Schopfer is a cardiologist and health services researcher at the San Francisco VA healthcare system, whose long-term goal is to develop, implement, and disseminate cost-effective strategies to improve delivery of high-quality cardiovascular care. In particular, he recognizes the importance of physical activity as a mechanism to reduce morbidity and mortality for patients with both ischemic heart disease and heart failure. His current work is focused on the utilization of cardiac rehabilitation services, which is inadequate at this time, and determining how to increase access to and participation in cardiac rehabilitation, utilizing new methods of delivery, including telemedicine and mobile technologies. Our second presenter is Karen Collins. Karen is a nutrition consultant specializing in cancer prevention and cardiometabolic health. She is a national expert who is called upon by numerous health professionals, organizations, to translate and present evidence related to the intersection of heart disease, diabetes, and cancer. And with that, I would like to introduce our presenters today. David and Karen, welcome.
Thank you very much. Appreciate it. Why don't we go ahead and get started with the learning objectives here. I'll just read through them for all the participants on the webinar today. I'm going to explain the recent literature supporting the case for home-based cardiac rehabilitation, identify and discuss some clinical cases appropriate for home-based cardiac rehabilitation, describe approaches and tools necessary to implement a home-based cardiac rehab program, and differentiate the unique roles of members of the care team that are executing home-based cardiac rehabilitation. So I'm going to begin talking about home-based cardiac rehabilitation programs and my experience in the Department of Veteran Affairs. The goals of the first half of the talk here given by me today is just going to be to cover a few things. One is how to implement a home-based program, discussing the types of home-based options available and kind of some lessons learned along the way and all the different kind of opportunities and models that exist. Two is going to be how telehealth can be used for cardiac rehabilitation for both identification but using it to appropriately tailor support for patients as they need it. And then a little discussion of just the importance of stakeholder engagement, both from leadership and clinical staff as well. So start off with the question of why do cardiac rehabilitation at home? Home-based cardiac rehab actually offers some unique opportunities and can remove a number of the logistic barriers that exist for a traditional facility-based cardiac rehabilitation as it's typically presented. Rather than having patients go into a facility up to 3 times a week over the course of 12 weeks, what is able to happen is that we're able to integrate behavior change into the daily lifestyle and home routine for patients. Some studies have shown that the effects actually may be a little longer lasting because they're able to kind of incorporate them into their lifestyle a little more easily. They have less fear about being active alone since a lot of times the transition from a facility-based, highly supervised program, then when discharged to home, there can be a lot of fear about that lack of supervision. And if we just kind of start with the expectation that patients are safe and capable of doing increased physical activity on their own, that can be very useful. And then we also are more readily able to incorporate spouses and family into the lifestyle changes, which is so critical because this comes up as a common issue of and perhaps Karen will talk about this a little bit more, is when we make recommendations such as diet changes and things, it isn't always helpful if that person actually isn't involved in the food preparation, for example. And so sometimes we're more easily able to get family members involved in the program. So what can home-based cardiac rehabilitation offer? Well, it actually offers really all the same core components that traditional facility-based offer. We provide smoking cessation counseling, discuss medication adherence with patients, address stress management, healthy eating, and we are, as I'll show you, able to actually provide very specific recommendations around physical activity and provide some monitoring for that, even though they're doing it at home. So to date, this is a slide kind of going over the summary of the scientific evidence for home-based cardiac rehab. There's been 23 trials that have randomized patients to either home-based cardiac rehab or traditional facility-based cardiac rehab or standard of care, and they've included a total of nearly 3,000 patients. But this includes ischemic heart disease, so after myocardial infarction, after coronary revascularization, and it's also included some heart failure patients in this. So it's kind of a diverse mix. But what has been shown is that there's really no significant differences in clinical outcomes when comparing home-based participants to facility-based participants, whether in the very short term at 3 months or the slightly longer term at 12 or even at 24 months. And that's looking at outcomes such as mortality, exercise capacity, some cardiovascular risk factors, quality of life as well. A marginally higher proportion of patients in home-based programs are able to complete the whole program, and we'll talk about that a little bit more later. And healthcare costs, though, have varied kind of depending on the country in which the program has been studied and the complexity of the program administered, essentially, so kind of the staff and the frequency of contact with the patient. So, but home-based cardiac rehab really can fill a void. I mean, there's the potential to actually lower overall costs for patients by providing this service, but it certainly provides more flexible scheduling for patients. As I said, it can reduce these travel and transportation issues that can be very challenging, particularly in older patients who are trying to get from home into a facility where they can do the cardiac rehabilitation. We can integrate it into their home routine. Like I said, there may be some evidence of greater adherence and sustainability over the long term, since there's less of a sudden change in going from facility and then kind of being discharged to home and saying, good luck, just keep doing it now on your own, unsupervised, since if we kind of get them incorporating exercise and all these lifestyle changes in their home right from the beginning, it can be easier to just kind of continue that process when the supervision from us starts to drop off. We can really reduce wait list and capacity issues, which can be a problem when you're using like a brick and mortar facility to provide a service, and you only have so many treadmills or so many bicycles for patients to use. And as I said, clinical outcomes have shown to be similar. So this is just an example of our home-based program. Currently, we started at the San Francisco VA about 5 years ago, and we have a multidisciplinary staff, a nurse, an exercise physiologist, we have a dietitian, and then physician, myself, supervising as well. And our participation in this kind of circle, the ring on the left, kind of shows you among all the consultations we receive kind of what the breakdown is of what the patients elect to do. We get around 350 consults per year, and of those, about 18-20% are ineligible. Another 1/3 of patients ultimately decline. That's the blue area in the right, bottom right. But you can see on the left half of the pie there, about half of our patients are agreeing to participate in some form of cardiac rehabilitation. It's a roughly equal split, maybe a little bit more preferring home-based to facility-based, but you can see that that's actually we've gotten our numbers in terms of initial participation up near 50%, which is a significant improvement above the VA's national average of around 10% currently. On the right side is a bar graph just kind of showing you the breakdown of the different clinical conditions that we have enrolled patients in our program for over the last 5 years, including myocardial infarction in orange, moving on into PCI. That makes obviously the bulk of our patients that we see, just because the volume of patients receiving coronary stents is so high. But then we have coronary artery bypass surgery in there, stable angina, a little bit of heart failure, and then we're seeing an increase now in the TAVR, the minimally invasive aortic valve replacement, and then regular surgical valve as well. make up the kind of round out the rest of the clinical cases. Our program is structured kind of in this way. What we do is we follow the same general model that facility programs do, and their model is 3 times a week for 12 weeks. So we've kept the same structure of we structure our program over the same 12-week period, but what we do is that instead of having contact 3 times a week with the patient, we actually just do once weekly either telephone or video calls with them, and you can see after they've enrolled, they kind of get weekly. They get 6 weekly sessions initially, and we break them down into biweekly toward the latter half. And some patients actually elect to have us to continue call them, and if that's the case, we kind of go down to kind of once a month calls if needed, if they still are requesting or requiring a little bit of further tapering. At the beginning there, kind of at month 0, what we do is we do a bedside visit while the patient is hospitalized with one of those clinical conditions that I just outlined, and we essentially clinically review them for appropriateness for home. We see if they would be safe to perform exercise and to receive the information at home, or if they're not and they really need more intensive supervision, then we recommend those patients go to facility. But for the ones that are essentially eligible and interested in home-based, that is the time at which we offer it, at the time before they get discharged, and we provide some education then. And then at each weekly phone call session are the numbers below is where we assess symptoms. We discuss how much physical activity they've been doing over the previous week, things like blood pressure, weight, whatever may be important for that patient based on what their past medical history and their risk factors are. Discuss healthy behaviors. We discuss kind of tailored education depending on their goals and their needs, and we continually kind of reassess what goals they have met and then keep setting new goals for the subsequent week. And so some patients, every program, and essentially every individual patient's program is a little bit different because every patient has different needs and different goals and things that they're worried about, and so we have tried to tailor our program to kind of match those interests and needs as best we can. If you're interested in more detail, this is just a reference for a paper we published a couple years ago, just kind of really in more detail outlining the design and the implementation of our existing program if you're interested. So our home-based program, like I said, we have a multidisciplinary staff, nurse, dietitian, the exercise physiologist, although some places use physical therapists as well, the physician. Mental health can be certainly a strong benefit, and having additional administrative staff help deal with kind of some of the tracking and management of all the paperwork can be helpful. What we do for our identification of patients and getting them enrolled is we have a number of ways we do it. We have automated reports from our electronic health record that tells us if patients essentially we get reports of troponin levels or myocardial infarction or things of this nature, so that we can identify patients that are hospitalized. We get the weekly cardiac cath and surgical list, so we know like who is going to be seen in the cath lab, who's going to surgery for cardiac surgery, and then we can kind of follow up with them and keep an eye on them and after their procedure, make sure that we go see them, and we round with multidisciplinary teams to just make sure we kind of don't let anyone fall through the cracks. From a clinical standpoint, our program, we do this bedside consultation is the way, while they're hospitalized, is our way to try to identify as many patients as early as possible and try and get them enrolled and explain the program to them right away. Many places, many facility programs, and others often use a delayed kind of phone consultation. They'll wait and get a referral for a patient many weeks after they get discharged. They'll call them on the phone and ask them if they're interested. And some of the evidence, there has been evidence that has shown that the earlier you contact the patient in their kind of eligibility time period, the more quickly or the more successful you are at actually getting them in to enroll. And so that the longer you wait, the less interested they will become. So we try to get them before they even leave the door, actually, although some patients we end up needing to call. We mostly do phone call visits on a weekly basis with our patients. Some patients we do have video calls with, depending on the need, and if the patient has a camera on, say, like a laptop or a tablet they can use. We do what we call asynchronous visits, meaning that patients are expected to follow their recommendations for physical activity and things off the phone with us, and then when we call, they kind of report back what they've been doing. We don't directly observe them doing exercise over the phone or through a video camera while they're doing it. That is not the way we do it, although that is certainly an option for some. We provide educational materials to patients. We give them an American Heart Association workbook and a DVD that can answer many questions, and we often use it kind of as a curriculum guide for us to walk them through, and it has nice references for them. We give our patients a Fitbit monitor that they wear with continuous heart rate monitoring so that they're able to quantify their steps every day, and that they use the continuous heart rate monitor on the Fitbit to kind of make sure that they're reaching their target goal when they're physically active, if we're setting that for them. We provide nutritional education a couple of times through our dietitian over the course of the program, and then we also offer psychosocial support to those who need it. Here's an example. So I'll just go over some of the other clinical aspects of our program. And here's an example of our nurse visiting with a patient at the bedside in the hospital, prior to discharge, and kind of explaining it to him. In this case, she's actually explaining it to him prior to even getting his coronary bypass surgery, because we knew he was on the schedule. So we kind of preemptively told him, here's what's going to happen after your surgery, here's what to expect, and then we kind of circle back afterwards and say, we would like to, get you enrolled in a program. On the left here's our nurse making a telephone visit. She's got the electronic record open. She's able to basically kind of make notes about how the patient's doing and discuss and answer questions, and provides education over the phone call. And on the right is our exercise physiologist, and he's actually using a video call in this case, and he was demonstrating and supervising some exercise for a patient who was doing some strength exercises, and he was kind of essentially monitoring them and giving them feedback on their form to make sure that they were going to be doing it correctly. This is the American Heart Association book that we give patients. It's called the An Active Partnership for the Health of Your Heart, and it's available directly from the American Heart Association. Here's an example of the Fitbit that we use. It's the Charge 2, and there are many other watches and Fitbits and types of things available. This is just the one that we've chosen, but there are many different options that have kind of continuous heart rate monitoring, and obviously certainly are able to track steps. We give patients bands to do some strength exercising, and most patients get a peddler, so that way if they can't leave the house to do exercise and go walk or anything of that nature, that they're able to at least sit in a chair and either pedal with their legs as a stationary bike substitute, or with their arms as well, to get some upper body resistance training in. And some of our patients are actually very motivated, and they actually really excel, and to the point that they request, and we offer a full stationary bike for them if they really don't have access to any other way to exercise locally where they live. So we do an automated referral system in the electronic health record. So after patients have had surgery or a coronary artery stent or a valve replacement, in our electronic record, in the order set, there is a box that's already checked that says refer to cardiac rehabilitation, and so that we've kind of removed some of the burden of referral from our providers and just kind of made it as simple as possible, so that they can, when they go through their checklist, we're kind of already just on the list and available for them, and we get the referral link and see the patients. We've developed a database so that we're able to kind of really just track our patients, because we have a lot of patients, and certainly the program itself is long, so from the time someone actually has an index event until they really complete a program can be upwards of 6 months or more. And just from start to total finish, and so we do track them to see how we're doing in terms of completing, getting patients to complete and enroll and participate in these kind of things. we have integrated some health tracking tools, like I mentioned. Some Fitbit is one example, and there are a number of applications. I'm not going to go into them, but there are a number of kind of web-based and phone applications, smartphone applications that you can use to kind of track your data. Enter blood pressure, enter your glucose, blood sugar, things like this, and that can make it easier for us to kind of track what you're doing and then to share that information with us. And I'll talk a little bit about gaining support from staff. This is just an example, like in our electronic health record, like there's a checklist, and right at the bottom is the cardiac rehab box, so it's easy to remember to include. Our database allows us to kind of share our numbers and our results with administration very easily, to kind of ensure that they support us and understand what we're doing, and we can show them an impact in terms of how many patients we're seeing and kind of what our enrollment numbers and such are. And relationship has been very important for us. We found that a lot of this has really, in the beginning, a lot of it was provider education, explaining what our program did, explaining who was eligible, really repeatedly kind of reminding and reinforcing that. But now I think we've kind of got to a plateau where we kind of, over the course of a year or so of doing that, we got to a place where now oftentimes providers are coming to us and asking us to enroll their patients, even when they're not always 100% clinically appropriate, and just because I think that they felt that we've provided a good service and are kind of looking for us to expand in ways that sometimes we're not always ready. But it's been very helpful to spend time with both administration and the various providers, surgical, cardiologist, internal medicine, and clinic, and discuss how we can get patients involved. So I'll just finish with a couple slides about some data. We looked at the impact of home-based cardiac rehabilitation on participation within the VA specifically. The VA started to implement home-based programs around 2011, and the number of programs initially there was a single one around 2010, 2011, and it has gone up to currently over 20 active programs within VA, and the data I'm showing here goes from 2010 to 2015. In 2015, there were approximately 15. There were 13 hospitals in the VA that had a home-based cardiac rehab program. So it went from a number of 1 up to 13 over the course of that 6-year span. And what you see in the dark blue bar is the participation rate in cardiac rehabilitation in the VA system at hospitals where there was not a home-based option. And it went from around 6% to around 11%, which actually was a statistically significant increase. Kind of just the general trend of increased awareness over the past decade and kind of attempts to improve cardiac rehab use. But what is interesting in the light blue is the participation when there was a home-based program available to patients, is that the participation rate really went up tremendously high. And more recently, we're now again approaching 30, a little over 30%. And at the end of this, you can see it's around 26 to 30% near the end. So there was patients who were hospitalized in a VA that had a home-based program available were roughly 4 times greater odds of participating than those who were not. When we looked at time to participation in cardiac rehabilitation, when we compared home-based and facility-based, we found that patients that participated in when home-based was available, the time from index event to first exercise session, kind of the first kind of phone call with us, was approximately 16 days. And when compared to some VAs that were using facility-based, it was an average, a median, of 62 days, and that was quite statistically significant. So using a home-based option, we were able to really get them enrolled and physically active and back up and recovering much faster than if you just went with the traditional facility-based model. And I think that's particularly important for clinical outcomes because, again, the faster patients start beginning the recovery process after a surgery, is critically important in shortening that time of recovery. And finally, we looked at just also completion as well, comparing facility-based and home-based patients. And when patients participated in home-based cardiac rehabilitation, they were consistently significantly more likely to complete a greater proportion of sessions. So in the bottom, it's just how many completed all 100% of their sessions. It was a quarter of the facility-based patients compared to about half of the home-based patients. And so you can see, depending on whether, no matter what we made the threshold for session completion, the home-based were always more likely to continue for longer. And so with that, I will finish and I will hand it over to Karen.
Great, thank you. Well, with the valuable insights that you learned from Dr. Schopfer, you can see why there's so much excitement about the potential that home-based cardiac rehab offers for helping people with heart disease rebuild their health and their ability to live the life they want to live. Now, I'm going to take a deeper dive with you to look at a few additional aspects of cardiac rehab. What do we need to consider to design an approach to cardiac rehab that will most effectively meet its goals? Exercise is central to cardiac rehab, but we need to be clear that effective cardiac rehab includes much more. Cardiac rehab includes specific core components known to optimize cardiovascular risk reduction, reduce disability, and help people develop and maintain healthy behaviors and an active lifestyle. So healthcare professionals from multiple disciplines are essential to deliver the comprehensive services that meet patient needs. This model illustrates components of cardiac rehab as Dr. Schopfer discussed and as are described in the position statement of the American Association of Cardiovascular and Pulmonary Rehabilitation. It begins with patient assessment that includes basic lab work and other tests, medical and social history, a risk factor profile, patient preferences and goals, all considered with the patient to collaborate in developing an ITP, individualized treatment plan, that's patient-centered and goal-oriented. This ITP addresses management of medical risk factors, blood pressure, cholesterol, and other blood lipids, and diabetes, and as part of that includes efforts to optimize medication adherence. Weight can influence all three of these risk factors, and excess weight is itself a risk factor. The ITP also addresses management of lifestyle risk factors, targeting physical activity, nutrition, tobacco cessation, and psychosocial well-being. So, for example, stress management, as well as screening for and treating depression. And the ITP includes education for self-management, designed to address each patient's specific health goals. When appropriate, it can be valuable to include family members and caregivers in knowing, understanding, and supporting the plan. This education is not just sharing facts, and according to the consensus statement of an expert panel convened by the World Health Organization, education will be most effective in reaching the goal of developing a long-term healthy lifestyle when it also influences health beliefs, increases optimism about the possibility of change, and heightens self-efficacy, increasing a patient's confidence that they can sustain a healthy lifestyle. Studies of home and community-based cardiac rehab programs show that greatest improvement is usually seen in physical activity. Blood pressure and blood cholesterol may improve modestly. Studies haven't reported much data on change in control of diabetes, despite its high prevalence among cardiac rehab patients and strong association with cardiovascular disease mortality. Data is often lacking to really assess changes in eating habits, but to optimize effectiveness of the cardiac rehab program, make sure these changes get the individualized goal setting and skill building devoted to other facets of the treatment plan. Statistics show quite clearly that obesity does not currently change to a meaningful degree in most people during cardiac rehab. Quality of diet matters, not only for primary prevention, but also for secondary prevention. This observational cohort study involved older adults from within 2 randomized control trials. All had cardiovascular disease or diabetes with end organ damage, and even with medications, and after controlling for physical activity, body mass index, and weight loss, compared to people with the least healthy diets, those in the top 2 quintiles for a healthy diet score had 20% lower incidence of a cardiovascular event, meaning cardiovascular death, heart attack, stroke, or heart failure. And of note, out of 70 possible points on this dietary score, those people in the top 2 quintiles averaged about 30 to 35 points. So they weren't eating perfectly, but they were eating better. With all the contradictory headlines today, it can be challenging to keep focused on the priorities that make a healthful eating pattern. Research shows that it's not so much how low or how high the dietary fat or carbohydrate. What's important is choosing foods with healthful kinds of fat and carbohydrate. Evidence-based recommendations call for eating patterns built around a variety of minimally processed plant foods, vegetables, fruits, whole grains, and beans. Foods high in saturated fat should be replaced by foods with unsaturated fat, like nuts and seeds, fish, and healthy oils. Overdoing carbohydrate with excess portions, especially sweets and highly processed choices, is not heart healthy and can lead to excess calories. And with today's abundance of high sodium convenience foods, limiting sodium means much more than just watching the salt shaker. Trending diets often include extremes that may be difficult to maintain long term or may not fit with evidence-based recommendations on diets that support overall health. We need to support a focus on creating a lifestyle that's sustainable. It's vital that health professionals, caregivers, families, and patients recognize that these characteristics of heart-healthy eating can be accomplished in a variety of healthy eating patterns. Though starting from a common basis of heart disease, patients' nutritional needs can vary depending on other medical conditions, such as diabetes or prediabetes and digestive health issues. For older adults, sarcopenia, the loss of muscle strength that's associated with several poor health outcomes, may be a concern that needs to be addressed. Moreover, behavior change intervention trials show that programs are more successful when they tailor efforts to meet individual needs. People can implement recommendations for healthy eating in ways that fit their family and cultural eating styles and flavor preferences. So, in setting priorities for the changes in eating habits that will be most valuable, cardiac rehab team members need to consider the baseline habits from which someone is starting. Whether center-based or home-based, cardiac rehab programs vary in how they leverage the expertise that registered dietitian nutritionists bring to facilitate successful change in eating habits. As we consider how to design an effective cardiac rehab program, results of this analysis published last year are well worth considering. If you hear someone suggest that, nobody really follows advice for healthy eating anyway, it's important to remember the difference between simply handing people generic handouts and engagement with dietitians and individualized care. As you see, compared to usual care, this results in greater reductions in blood lipids, reduced medication use, and cost savings. And the more engagement people can have with the dietitian, the better the results. Obesity among patients in cardiac rehab remains an unresolved challenge. Everyone working in these programs sees it, yet most have not felt equipped to deal with it. Among cardiac rehab patients, over 80% have overweight or obesity. A half to two-thirds of cardiac rehab patients have type 2 diabetes, prediabetes, or metabolic syndrome, conditions strongly related to excess body fat. So as we look at how to design an effective cardiac rehab program, it's worth considering how we can address this. Patients often view cardiac rehab as an exercise program, and they assume that means they're bound to lose weight. Actually, weight loss during cardiac rehab tends to be minimal. Standard cardiac rehab exercise generally doesn't require a lot of calories, and in the context of an overall lifestyle that's largely sedentary, it's not enough to promote weight loss. Estimates of calories used in exercise on treadmills, fitness trackers, or phone apps are based on algorithms and generally overestimate true calorie expenditure. Moreover, we live in what's been termed an obesogenic environment, where large portions of foods relatively concentrated in calories are available 24/7. Unplanned eating to deal with stress, depression, or boredom makes it easy for calorie consumption to surpass calorie needs. Or some people aiming to eat more healthfully may add foods they hear are healthy, but adding them to what they're already eating rather than swapping them to replace less healthful food ends up increasing calorie consumption. When patients hear weight loss, they often think we mean going from having overweight or obesity to the weights they see listed on charts as a normal BMI, body mass index. As health professionals, we're usually talking about a 3, 5, or 10% weight loss, and that's an important clarification. Current evidence-based guidelines note that even a 3 to 5% weight loss can be clinically meaningful in improving risk factors in adults with overweight or obesity. For many people with obesity and type 2 diabetes or high blood pressure, some recent standards of care say weight loss of at least 5% is needed to produce beneficial changes in these risk factors. And the clinical benefits of weight loss are progressive, so more intensive weight loss goals of 10 or even 15% may be appropriate. But importantly, the goal is a moderate, sustainable loss, not a rapid or large loss that's unattainable or unsustainable. Cardiac rehab programs that added a behavioral weight loss component have achieved clinically significant weight loss. To optimize the effectiveness of a program, we need to maintain the perspective that cardiac rehab is not only a rehabilitation of cardiorespiratory fitness, it's also a rehabilitation of a lifestyle and outlook that promote health. Published reviews of randomized controlled trials of programs for preventing and treating cardiovascular disease show that many don't take advantage of all that we've learned from behavioral science about how people change behavior. The first aspect of individualizing care is to assess someone's readiness to change. Motivational interviewing is a patient-centered, collaborative way to explore and resolve patient ambivalence, relating their values and perceptions to cardiac rehab goals. Rather than inundating a patient with mass quantities of educational material, likely adding to a sense of overwhelm, education should be personalized to address the needs we've helped the patient identify. As part of that motivational interviewing, a patient may describe a variety of barriers. Perhaps they never developed skills for cooking, grocery shopping, or healthful ways to manage stress. Perhaps it's difficult remembering to take medications, or there's a physical or social environment that discourages physical activity and encourages unhealthy eating. Information alone does not resolve those barriers, but we can work with a patient to find options in their environment, create cues, and identify role models who demonstrate steps that are realistic for that patient. Regardless of knowledge of what to do, lack of social support can be a major barrier to implementing that knowledge. We can help people discover sources of support and even practice the skill of asking for support they want. Just as a toolbox full of screwdrivers is not as helpful as a mixed set of tools, we have a toolbox of approaches we can use to support a patient in meeting their goals. For example, the way goals are set makes a difference in the likelihood of achieving them. Motivational interviewing is a technique using open-ended questions and reflection that helps a patient identify goals that are meaningful. Self-monitoring, whether done on paper or using technology, is a feature of most programs. To maximize effectiveness and keep it from becoming just a tedious, guilt-producing task, frame this record keeping in a positive light as a tool for learning and problem solving. Cognitive restructuring is a powerful tool to help people identify thought patterns that are working against them and replace those patterns with more positive ones. Processes like this take real attention from a patient and health professional and are unlikely to take place while someone's concentrating on exercise or not feeling the safety of privacy. Home-based cardiac rehab is a setting in which we can take time to do this as part of a session. The skills of adding and removing cues, problem solving, and dealing with lapses in behaviors also contribute to achieving behavioral goals. By intentionally using these tools with patients in cardiac rehab, we're not only giving them the fish they need for today, that is, helping them meet their goals, we're also teaching them to fish, giving them skills they can use to maintain those new habits after cardiac rehab is over. If goals are to be the North Star toward which a patient is steering and by which progress in cardiac rehab is assessed, let's make them as valuable as possible. SMART goals, collaboratively set, should be specific, no vague ideas like eat healthier or walk more, what will be done, where, when, and how. Measurable, how will someone know if they're 100% successful or partly successful? Action-oriented, the goal is an action, so not a blood pressure drop or weight loss, but an action that the patient takes. Realistic, is it within reach at this time? And time-bound, with an identified time to start and to assess progress. By promoting active patient engagement, we bring them into the behavior change process. Tracking behavior is helpful when it's related to specific behaviors identified in goals. And studies show it becomes more valuable when that tracking data is reviewed and used to shape next efforts. In some cases, family members and caregivers might be brought in to celebrate progress and to do problem solving based on the results seen by tracking. Some people may feel they're lacking positive social support, and helping them find appropriate sources can be valuable. While home-based cardiac rehab lacks the camaraderie of a center-based program, other options for group involvement within or outside the program can provide support and opportunities for a patient to be actively involved in their progress toward being more active, eating well, and making other healthy lifestyle choices. Beyond its ability to promote engagement, mobile technology can be a valuable tool to support behavior change. At one time, we might have assumed that the older adults who are typical cardiac rehab patients would not be comfortable with texting or apps that are cell phone or tablet-based, but especially for the lower risk, less frail people for whom home-based cardiac rehab is appropriate, many are comfortable with technology. In a time when grandparents are doing video chats with their grandchildren, don't rule out mobile technology as a tool in cardiac rehab. Communication using multiple different touch points seems beneficial, according to some reports. So, for example, this could include phone or video coaching and a variety of apps for behavior tracking, education, and support. A wide range of tools is available to enhance education and skill building. In fact, such an array that it can be overwhelming for patients. Build a library of options that you can selectively recommend to support particular goals that fit varied patient learning styles, comfort with technology, and preferences. Depending on an individual patient's goals and what barriers pose the greatest challenge, they might find healthful eating easier with help from apps for meal planning, where they can find recipes, create a file of favorites, develop a week's meal plans, and then automatically generate a grocery list of what's needed. If grocery shopping is a challenge, there are apps that can evaluate specific choices to meet individual needs, such as lower sodium, higher fiber, and more heart-healthy fats, and suggest options for more healthful choices. Some people for whom frequent eating out poses a barrier to healthy eating may find that with ideas for quick meals at home, they will no longer eat out as often. Others may find that an app that helps them eat out more healthfully is a valuable tool. For that matter, apps for smartphones or tablets can help people explore other new skills that range from deep breathing for stress reduction to support for tobacco cessation or yoga. And there are plenty of tools available for use in home-based cardiac rehab that don't rely on apps. You can create a library of fact sheets and videos grounded in evidence-based recommendations that are available free of charge. Through these, you help people learn more about specific healthy choices related to their individual goals in particular situations, whether it's label reading, eating more vegetables, or reducing added sugars. Some free resources for supporting healthy eating that are available include printed material from the National Lipid Association, or NLA. It's found in the Clinician's Lifestyle Modification Toolbox on the website. This includes tip sheets for a healthy diet, as well as counseling tools we've discussed, such as assessing readiness for change and setting SMART goals. The Preventive Cardiovascular Nurses Association, PCNA, also offers a heart healthy toolbox, which provides tip sheets such as small changes to reduce sodium or choose smaller portions, as well as tips on reducing time spent sitting, getting better sleep, and using positive self-talk. Videos can be an engaging tool for sharing information or demonstrating specific cooking skills or recipes. Before recommending these to a patient, I strongly encourage you to have a dietitian from your team screen any nutrition videos that aren't from the American Heart Association or other authoritative organizations. A wide range of videos on YouTube present views on nutrition that are not based on the overall picture from current sound science. So don't simply encourage a patient to do a search there or on other search engines or go by title alone. Movies on network TV or streaming services may promote a slanted view of eating choices that don't reflect overall research or recommendations. So if videos are a good vehicle to support education and behavior change for a particular patient, don't leave them on their own to find what's accurate. Provide solid recommendations. Finally, a few additional resources. The Cardiac Rehabilitation Change Package, developed in a partnership between the Million Hearts Initiative and the American Association of Cardiovascular and Pulmonary Rehabilitation, aims to help hospitals and cardiac rehab programs implement strategies and systems that target improved care in several focus areas. It includes specific actionable ideas with tools and resources that can be used or adapted to improve cardiac rehab referrals, enrollment, engagement, and adherence. Million Hearts site itself is a great source for heart-healthy recipes and resources to support tobacco cessation and medication adherence. The Healthy Living section of the American Heart Association website also provides resources on eating choices, recipes, movement in daily life, and stress reduction. For optimal use of these and other resources, review them in advance and have them tagged to best identify choices that will meet individual patient needs to surmount the barriers they've identified to achieve the goals of their individual treatment plans.
All right, everyone, is it time for Q&A then, yes?
Yes.
Super. Okay, thank you, Karen and David. Lots of great information. Okay, everybody, it is time for the Q&A portion. So send in those questions for David and Karen here, and we will get right to them. And let's jump right into it here, presenters. What is the gold standard as far as cardiac food and diet?
Well, I'll jump in on that. The gold standard has really changed, that it's no longer focused on a particular standard, like only looking at saturated fat or sodium. Those are both important components, as is avoiding excess added sugar. But as in the slide where I was showing the healthy dietary pattern, it's really the overall pattern that focuses on plenty of vegetables and fruits and whole grains and legumes, and avoiding excessive amounts of foods that are rich in saturated fat.
Okay, great. Next question, presenters. Do you know if Medicare covers home-based cardiac rehab?
No, Medicare does not currently cover home-based cardiac rehabilitation. That is an ongoing effort by a number of us in the field to work towards. It is reimbursed by some individual payers on a state-by-state basis, and there have been a number of kind of other workarounds that have been proposed, such as using some other chronic care CPT codes and things of this nature, but it's a work in progress to get it covered by Medicare.
All right, thank you. Next question, presenters. We often find many issues related to abnormal vital signs, increased weights, and arrhythmias during rehab sessions, indicating that medical intervention is needed. How are these detected with home-based cardiac rehab?
So the studies have shown that although a number of these arrhythmias are often noted during exercise sessions and things, that they're usually benign. There are a lot of safety data out about the number of hours of exercise that patients in cardiac rehab do, and the event rate is usually one event in every somewhere between 60 and 80,000 patient exercise hours. And that's among all comers, and that includes some older patients and older data back before we had some of our more effective interventions in medical therapy. So arguably it may even be safer today than it was 10 years ago. But safety data would show that it's actually quite exceedingly low, and that if we're talking about getting thousands of patients to be physically active, it's not to say that there won't ever be something bad that happens, but we still do surgeries, even though sometimes bad things happen. So there's some degree of risk that has to be kind of appropriately assessed, and make sure that you think that they are low risk and that they're not at high risk of event. But there's no. But otherwise, the only things that we have are kind of the emerging technologies around monitoring heart rates and rhythms and things like that. But those are still works in progress.
All right, great. Next question. How is the nutrition education delivered? Is it via a phone consult, in person in the home, a recorded webinar, or provided on a DVD or a thumb drive, or how do you distribute that information?
This is where programs vary all around the country. Home-based cardiac rehab is still in its early days, as Dr. Schopfer noted, but it can be done as part of that weekly check-in session. Or one of the things that can be very valuable is if there are barriers that are identified or problem areas that are identified, then if a dietitian is not on that particular call, they could make a referral to have a session with a registered dietitian nutritionist, as well as identifying particular materials, whether that would be those downloadable handouts I mentioned or videos or other tools, to target the specific behaviors that someone's having trouble adopting. So the important thing is just that we act on it and don't ignore it.
Okay, great. We got a couple similar questions here, which I'm going to kind of bundle together here. You were talking earlier about some apps. Do you have any specific meal planning apps that you recommend or that you've liked that you've used with patients?
I'd rather not identify any particular ones now because they're generally have some kind of commercial basis. But there are a number out there that you can just do a search in a toolbox, and the main thing is to check that those the meals do meet this perspective that I shared, that it should be an overall focus on whole plant foods. But it does not need to be a vegetarian diet. It does not need to be any of the extremes. And even helping a patient to walk through some of the options, that can be great education for them to learn how to evaluate information that's out there and choose things that really reflect what the current recommendations call for.
All right, very good. Next question. In our hospital, we encounter many patients that are post-cardiac surgery. They are with us for 10 to 14 days for acute rehab. Many of them struggle with the required intensity of 3 hours a day. Would you find it more beneficial to enroll a patient prior to an acute inpatient rehab or enroll them after their acute rehab?
I think a home-based model and what's been discussed a lot is kind of hybridizing some of these, is to just kind of I think the home steps in as kind of an opportunity to kind of help transition patients, because certainly we can't, if we're not talking about enrolling someone in a rehab program indefinitely, then what I see is that this is an opportunity for someone to go from an acute rehab and it can help them with that transition process, rather than feeling like they are, although they may technically be ready to be discharged and go to home, I think we all can recognize that that patient is not going to continue to do the level of activity and adhere to the changes that are recommended, in a completely unsupervised setting. So this allows for a bit of a transition from an intensely supervised setting, to then a transition them to at least some either, it could be telephone calls, it could be video calls, it could be a home visiting nurse once a week for a month, for 2 months. I mean, there's all kinds of different ways, it could be structured, and they've all been studied, they've all been looked at, people trying different things, and I think the bottom line is that there's no one solution for everybody, but I think home could fill a bit of a need, a little bit of a gap there for that kind of patient.
Okay. Next question. Are there any reimbursements for the home-based rehab services?
So like I said, I mean, there are individual payers on a state-by-state basis that are paying for it, but at the national level in the United States, there is not. Medicare has not yet. There's, like I said, there's growing effort now to go to them and to try and get them to support it, because typically once Medicare does, most payers kind of fall in line with wanting to pay for at least what Medicare pays for. But it is covered, say, in the UK, Canada, Australia, etc. So that's where a lot of the scientific research has come from to date.
All right. How are you determining initial activity levels for your patients?
So we do a 6-minute walk test with the patient kind of at the time of enrollment to assess a baseline functional status and to look at their heart rate when they're doing that. We assess their symptoms with the Borg scale, which is kind of a traditional scale for measuring kind of subjective exertion. And we put that together. Our exercise physiologist puts that together and helps kind of determine an initial exercise plan, essentially for the first couple weeks, first few weeks to get the patient started, whether it may just be really just light walking, or some patients, depending on what they had, if maybe they only had a PCI and they're actually pretty active at baseline, they may be ready to go, straight to a little bit of, light bicycling or something like that. So we do a 6-minute walk test, though, to do a kind of a baseline functional assessment.
All right. Are you utilizing social workers on your interdisciplinary teams?
Karen, do you? I'll say we do not, in terms of like just a standard of care, use social workers as part of it. Although oftentimes we do round with our multidisciplinary teams, which have social workers, and so we will speak with them and try and get an understanding of patient's home situation and their needs and where they're being discharged to. But I don't have one on my staff, for example, that works full time just for cardiac rehabilitation patients, though.
Okay.
From what I've heard of programs around the country, some will use a social worker. I mean, there's that psychosocial piece, right? So that could be filled by a behavior scientist, that could be filled by a psychologist. Some social workers might address that piece. And otherwise, this is another case where having that team that Dr. Schopfer mentioned, if, for example, food insecurity is behind someone's unhealthy eating, making the referral to a social worker who can get people linked up with assistance could make all the difference in the world for someone. So they can be a very valuable part of the team.
Okay. What factors would indicate home-based cardiac rehab is better for the patient as opposed to a facility?
Honestly, if they won't go to facility, but they are willing to do home, then I say that's the case when home is better. If a person is willing to do facility as well, they're open to anything, then I think facility probably offers a somewhat more intensive exercise program. I mean, certainly it's supervised. It's 3 times a week. There are certainly kind of greater expectations for what the actual exercise program is for that patient. But I see home-based as kind of filling a need and a gap for patients that either aren't able to access a facility program or are not willing to. So at the moment, without home-based, the only option would be to say, okay, well then I guess they're not going, right? Well, here's an alternative option where we can say, well, what about doing it at home? What if we call you? What if we, don't put as much of a burden on your daily routine, which can be due to a whole number of factors. And if we can get those people to say yes, then I think that's who it's better for, because it's better to do home than to just do nothing. So.
Okay. Well, David and Karen, we are just about out of time here. We've reached the end of our hour. But I want to thank you for joining us today for a great presentation. Thank you so much.
Thank you.
Oh, thank you. I'd like to thank the American Society on Aging, Right at Home, and today's Geriatric Medicine, and to everyone who participated. And for help dealing with today's information overload on nutrition, if anyone is looking for more help, I'd love for you to check out my website, which is KarenCollinsNutrition.com. And you can sign up for email updates of my blog or any other way that I can be of help to you in your journey to support these patients.